everybody. Hi, thank you so much for joining us today for this session when PH patients need surgery. This session will run for 60 minutes, and the panelists will briefly introduce themselves and share their connection to the PH community. This session is being live streamed on our website today, so thank you for all of those who are joining us from your homes, and please feel free to ask questions in the chat as well on there. These sessions are designed to be interactive and engaging through an in-depth discussion and question and answer period. Please, I believe throughout this session we'll want people to be engaged, so you're welcome to ask your questions throughout, I believe. Yep. And the same if you're at home. Yeah, so please join me in giving a warm welcome and thanks to our panelists for their time and expertise today.
The important thing to realize is that if you don't ask us questions, we're going to ask you guys questions. Okay? All right. So we insist on this being, we are here for you today. And so it's wonderful to see everybody. Fran, kick us off here, my friend.
All right. Good morning. Thank you for joining us, those of you in the room and those that are out there in the virtual world. Thank you for joining us. I'm Fran Rogers. I'm the nurse practitioner at Temple University Hospital in Philadelphia for our pulmonary hypertension program and our CTEF program. And I am the current immediate past chair of PHPN Executive Committee.
My name is Bill Auger. I'm emeritus professor at the University of California in San Diego. That's a fancy way of saying I'm kind of retired.
He'll never retire.
Oh, listen. I spent the bulk of my career at UCSD in the field of chronic thromboembolic disease and CTEF. Last few years I've been at Temple where Fran had to put up with me, poor dear. I'm pretty much doing the same work, but working in the pulmonary hypertension community. And my link with PHA, given my age and my white hair, has actually been quite long. In fact, one of my patients was the founder of PHA, and so that's how long I've been around. But I'm currently a member of the Scientific Leadership Council, and very happy to see everybody here in 2022. And thanks for coming today.
So, thank you. Thank you everyone for being here. I know people can't see from virtual, but we had standing room only, so we were very happy. My name is Dr. Jean Elwing, and I'm from the University of Cincinnati, where I've been there about a decade and a half. And I'm the director of the pulmonary hypertension program. And my involvement of PHA through the years has been different over time. I was so proud to be able to help with these sessions in the past, and I am on the oversight committee for certification.
Great. Just be happy we're not going to go around the room and ask you to. Then the session be over. You want to start?
Well, yeah, sure. What we thought we would do is ask you to ask us what you are concerned about if you're facing or are going to face surgery having PH or CTEF. So this way we can make it interactive, right, as Dr. Auger said, right from the get-go. There's no wrong answers, there's no wrong questions, so don't be afraid to ask. The only silly question is the one that goes unasked. So we could start out there. I mean, we know what we'd like to talk about, but we want to hear from you right from here. What do you think you'd like to talk about first? And Laura will make sure that you have a microphone. Okay, she's going to bring the microphone to you.
I don't think that mic's on.
Hello? Is it on?
Okay, my question is not regarding anything that's related directly to pH, but it is on the surgery scope. I wanted to know what are your thoughts regarding elective surgery for pH patients?
Oh. You want to take it or you want to?
Sure. So I think all three of us would tell you that it all really depends on the status of your pulmonary hypertension, how well controlled you are and how much lead time we have to prepare. And so that really takes a really close interaction between you talking to us, we talking to the person who wants to do an elective surgery, and we reevaluating your pulmonary hypertension. And what do you think, Dr. Auger?
Well, first of all, that's the perfect question to start us off, okay? Because that's exactly why we're here. Well, let's talk about, or let's kind of get to the same level of understanding. Is that undergoing surgery, and mostly it's undergoing anesthesia, is a really big deal for everybody. I mean, it provides a physiologic stress on our system, our body, the kind of gases and the kind of materials that they use in order to make us comfortable during an operation often lowers our blood pressure, puts us, it soothes our heart, it obviously soothes our brain, and so there's a lot of physiologic changes that occur as a result of anesthesia. General anesthesia in particular, a little less so with epidural anesthesia, and really a lot less so if you're doing local anesthesia. For example, numbing up your jaw or your face if you're getting dental, or your teeth if you're getting dental work done. So there's various levels of anesthesia in order to keep us comfortable and calm during a procedure, but it can, as you get into general anesthesia, there's a tremendous physiologic stress on our system. So for those of us, for patients with pulmonary hypertension, it's a concern, because in order to keep us calm and safe during an operation, our heart has to respond to those stresses. And if you have pulmonary hypertension, it's harder for our right heart to keep up with those challenges. And so that's why, the overriding, and I'm giving you a long answer, but that's what I'm up here for, right? But the overriding concern and the overriding thing that you need to be aware of if you're undergoing elective surgery is to work with your pulmonary hypertension group. That's number one. The first phone call after you're done with your doctor and your surgeon and they say you need an operation, pick up the phone and talk to your pulmonary hypertension practitioners, the people that are taking care of you and and make that phone call. Because at assessment, they know you the best. They know what level of pulmonary hypertension you're dealing with, what medicines you're on, okay? And they also know this surgery, what level of risk do we have here, and what needs to be done, what prior planning needs to be done. So it's really, really important that you all do that if you're faced with an operation, because it's so variable. We're all different. Every single person in this room is different, and so your risk relative to the risk of surgery needs to be assessed, and the best thing to do is work with your team. Did I give a good answer?
You did wonderful. And he has that booming voice.
For a clot doctor, huh? You did okay.
I would just want to elaborate on one thing that you said, coming from the office side, because our nurses and myself, we focus a lot on that, is the timeliness of our patients telling us that they need an operation. Even if it's elective and even if it's relatively small, we want to make sure that you go into it as well as you can be, and your right heart is protected as well as it can be protected. And in some instances, if we get that call on a Thursday and your surgery's Monday, we are more than likely going to say, we haven't seen you in a bit, you're going to have to postpone that. And we need to be in contact with your surgeon. And in most cases, they will fax us and tell us what the surgery is, what type of anesthesia they plan to use. And then, the ball is in our court, as it should be, to get you in if we need another echo. Maybe you need a right heart cath. We've got to get you optimized so that you have a safe and as good of an outcome as you can from whatever that operation is. But I would say timeliness is very important, so give us as much time as you can so that we can make sure all your ducks are in a row. If we have to talk to that particular institution about your meds, we will be absolutely happy to do that. More than likely, you're going to have to take them with you, because if it's a community setting, they won't have them. If it's a larger surgery and we're concerned, we would, in our practice, we'll ask you to have your surgery at our institution. And we often do that. And then we have kind of control over everything. We know our anesthesiologists very well that work with our patients. Again, the bottom line is to give you the best outcome possible. Just give us the time we need to do that.
Definitely, I echo that, Fran. And the other thing that's really important is that we are able to have that time to talk to the person that wants to do your surgery. Because maybe when we talk, we can say, maybe that surgery in that location is not the best option. And once they have that conversation with us, they oftentimes will be very happy to get you to the safest place. And many times the safest place is with your own PH center. Because of the complexities, not only of doing surgery on someone who has these special medicines, but the anesthesiologist has to be specifically trained in how to manage your time in the operating room and after. So it's much more complex than what meets the eye. Even a simple endoscopy can be very complicated for a PH patient.
Now, we will get to your, there's some folks want to ask some questions up here. But also, I want to emphasize as well, there was a key word in your question, which is elective surgery. And that's what we're talking about right now. It's more of a challenge, but still the same process it's just going to be, the tougher situation is emergency surgery. But you or your caregiver, even in that setting, should try to contact us as soon as, because, we have people on call, people who, if it's an emergency, it's an emergency. We need to do the best we can in order to get your care provided for in the safest way possible.
He's okay. I promise. I'm a doctor. I checked him out. So,
I got a tickle in my throat.
do you want a water?
Yeah, I do.
Yeah.
Go ahead. So there were some questions?
Yeah. Next question? Oh, yes, sir.
I was just wondering, can you define when you say surgery? Are you talking lungs? Are you talking heart? Are you talking combination? And secondly, is this the type of surgery that once you do it, it's one and done, or is there something that you see it happening every 10 years or something to that effect?
It sounded like your question was about a specific surgery. It's not the clot surgery we're talking about. We are actually talking about any kind of surgeries here, be it an abdominal surgery, a chest surgery, an orthopedic operation, dental surgery, endoscopy. So we're talking in general terms here about any kind of surgery. And each kind of surgery has a level of risk that's what we're here to help you with, assess that risk as it pertains to your particular situation and your level of pulmonary hypertension. Because, and again, I'm going to stop talking because I don't want to, because I'm choking to death here. But no, but I want because it's very important whether, let's say, you're only taking oral pulmonary hypertension medications versus you have an infusion pump. So the level of what needs to be done is going to be different. Yeah. The level of attention is going to be different, okay? Depending on what your personal situation is and what kind of operation needs to be done. How long are you going to be unable to take oral fluids, so on and so forth, post-operatively. So that's where people like, Fran is our master in trying to coordinate that kind of care around your operation.
So we even want to hear about dental stuff, as Dr. Auger mentioned. We want to know that stuff is happening, and your dentist actually wants to talk to us. because there's medicines they give you when you have your teeth taken care of that may not be safe for you in certain circumstances. We might decide that you need to be done in terms of your dental work in the operating room. I mean, there are things that there's no way they can understand until they really get down to talk to us and say, oh, that's a little bit complicated. I didn't realize that medicine was so specific, and we don't have that at our hospital. So I think that's really important. And then you talked about emergency surgery. So we definitely want to know about that. Even if you're like going into the operating room because you have an appendicitis and you need that surgery right now, we want to talk to them because maybe you won't be able to eat or drink after your surgery for a day or two. We got to have something to replace the medicine you're on if you can't take it by mouth. Or if you just need a longer time to recover, how do we do that in the best way if they don't have the medicines on their formulary? You might have to have your surgery, recover, and then we need to figure out how to work with your family to get you your medicines. So it is, there's always these unexpected bumps in the road when pulmonary hypertension patients have surgery, and sometimes we can't even foresee them when something's urgent, but we just have to be open communication lines so we can help guide you through those complexities.
I agree. That's what we want, again, is we want the best outcome for you, but even if it's an emergent surgery and we're not finding out about it until immediately after, what we may do, and we've done this in the past, is once you're stabilized enough to be transferred to our institution, we will, especially if there's some complications that we know we can handle better in a PH center, and usually the physicians and the surgeons at the hospital you're in will be very happy to do that because they know that we're the ones that do it every day. It's what we do every day, day and night. So we just want to, again, do what's best for you. One thing I would say is, if you're going in for surgery, just make sure you let your specialty pharmacies know that you need if it's time to get your medicines like in the next 2 weeks, just get them a little bit early so that you have more of them in case you have an extended stay that we didn't anticipate. Now, in our institution, most of our drugs are on formulary. Some of them aren't, but most of them are. And then this way you won't be without drug, and there won't be this scrambling if you happen to be doing okay, but you've got to stay an extra couple of days. And we do not want gaps in your therapy. We don't live in a perfect world, and sometimes it might happen a little bit, but I would advocate that you advocate for yourselves in those instances to make sure you have enough of your medications before you go in.
Okay.
I have been put to sleep 5 times since October. 3 of those times I coded and had to be put on a respirator. All of these were not elective, but yet they were. They was 3 stomach scopes, a heart conversion, and then a heart ablation. What can I do, even though I let the anesthesiologist know, hey, look, I've coded 2 times. What else can I do other than telling him and making sure he knows that I have PH? What can I do on my end to get that out?
Okay, so this is real. What you experienced is real, and honestly, I've met more than one person after they've had this event happen when they went to surgery because they didn't know they had pulmonary hypertension. They go to surgery and they have this time where they can't breathe on their own, or their heart doesn't work exactly the way it's supposed to, and they need extra help, like a breathing machine. That's the conversation we all want to have. We want to talk to everybody on your team that's doing these procedures, and maybe we want to do them in a higher volume center in a way that keeps you as safe as possible. And if we have to do surgeries, if there's no other option, then we have to have all these backup plans. Like I actually work with a cardiac anesthesiologist, and she is a wonderful lady. We keep lists of every single person that's going to have surgery, and she's watching them. And then each person goes to a pre-anesthesia clinic and gets a prep for what we're going to do. And then we have conversations in Epic, try to make sure we got the right anesthesiologist for you, and we loop in your surgeon so they know exactly what's going to happen. And if you're not feeling good, we cancel the surgery and reschedule. So we are really working in the background when we know about it to try to keep you as safe as possible. And there's things that people need to have done that are really serious. And we have even backup life support machines that can help people get through those necessary surgeries, but we have to know and be it all planned out so we can have that done properly.
And so, I know this, it sounds like, it's so frustrating, and I understand how, it's been, it's probably been a difficult time since October for you, to go through all that. And I just want you to know, you did the right thing. You told your anesthesiologist, but make sure that anesthesia person has also talked to your PH team and to the docs that take care of your pulmonary hypertension, so there's, a coordinated effort to provide you with the best anesthesia possible to minimize the risk. Because sometimes it does happen. Sometimes things do happen. You have to be put on a ventilator, but and even that takes, coordination with your critical care physicians, your intensive care docs as well, in order to do that properly. And so it truly takes a village here in order to properly care for you during these stressful times. But you did the right thing. You let people know that you had pulmonary hypertension, but also ask them, hey, have you talked to Dr. Jones about my pulmonary hypertension? Because, I've been working, I've been here with the PH team here for, 15 years or whatever. And they know you the best. They know your meds. They know the challenges you're going to be faced. And so you did good, but make sure that they're doing good too, and talking with your team. Why don't you just stand up when you have a question?
Sorry, we have a question from the live chat that we'd like to get answered.
Okay.
What's that?
Live
We have
chat
a question
question.
from the live chat. Somebody asked, with an oral surgery, is a Novocaine shot best versus nitrous oxide gas?
Oh, that's an important question.
Sorry, I didn't hear the.
When somebody's having oral surgery, should we use just the lidocaine, Novocaine, or should we use nitrous oxide? And this is a tricky question because it can easily get mixed up with nitric oxide, which is good for you usually, or not at least bad for you. But nitrous is something we actually try to avoid in patients with pulmonary hypertension, and that's why, like, who would think that, right?
That's a really good question.
Yeah.
That's exactly right. Because not all of us are chemists, and so then there's a big difference between nitric oxide and nitrous oxide, and so and as Dr. Elwing has noticed, we typically avoid the use of nitrous oxide for a lot of reasons.
So I think there is another question closer to the front here, midway.
This is great. Just keep them coming. Come on. Rapid fire,
I was under the impression from talking with a couple of surgeons that if you've got pulmonary hypertension, that elective surgery was elective and therefore you should never do it. For instance, hernia repair, that sort of thing. And what are your thoughts on that? And my other question is, why is the heart pressure, 35 is the number that they look at? Anything over that, you don't want to do surgery. How did you determine 35? Why not 30? Why not 40? How much do you vary off of that?
He's a liver patient who is interested in transplant. That's why the 35 is Fran, do you want to take that?
So a couple things. As far as elective surgery goes, I would think, and I think my colleagues would agree with me, because it's elective doesn't mean that you shouldn't have it. I mean, there's a risk-benefit that we always look at.
Perfect.
As when you're and it would happen to any of us. You know, what are the risks? What are the benefits to have the surgery? What's going to happen if you don't? If you're in the right setting and your pulmonary hyper team is actively involved, I know we keep saying this, we have often gotten people through elective surgeries, from hip replacements to knee replacements to removal of their gallbladder, and they do fine under our close watch. So I think, I don't think anybody should not consider elective surgery, but have a conversation about the risks and the benefits if you don't do it, or if you do it, you should be under, we really recommend that you do it with your PH center. And then as far as the number you mentioned, not sure about what
Yeah.
means.
Go ahead, please. So Fran, it might be related to certain special surgeries like transplant. We look for, so I
You
don't know
mean
if you want to speak.
35?
Yeah, where we got the 35 number from.
Please, go ahead.
Okay.
No, go.
So,
I'll just sit here and try to look as good as possible.
Oh, no, you couldn't possibly
so
look any
there
better.
are some special circumstances where we do look at numbers based on data we have from bigger groups of patients. And one of those things is liver transplant. And we have to get to certain numbers before patients are a potential transplant. And that comes from older data from the Mayo Clinic. And, you know, we're always looking for more information and more, and, you know, newer things come out, and things may change over time. But that's the kind of the number we are looking for. This is the average pressure we look for to kind of say, hey, this person may be a safe person to undergo liver transplant. But when you're talking about chronic PE surgery, it's a totally different ballgame, though.
Yeah, I mean, it doesn't matter, well, yeah, it doesn't matter what your level of pulmonary hypertension is, we'll go for it. If it's due to, if the chance of removal of organized clot from your pulmonary artery, if the chance of success is so great, it doesn't matter what your level of pulmonary hypertension is. But this underscores exactly the first part of our session here, the discussion we had here, is that every situation is different. Every situation that you're all going to be facing with your pulmonary hypertension, undergoing any kind of surgery, is different. Risk versus benefit. Fran said it perfectly. If you have a little hernia, okay, and it's not hurting you, but it's, you know, it looks weird, you know, and you want to get it taken care of, well, you'd have to think twice about doing it if you have significant pulmonary hypertension and on 3-drug therapy. You know, really, what's the benefit of fixing that hernia versus the risk that you're taking by undergoing general anesthesia? That's a risk-benefit assessment. If in that hernia, all of a sudden part of your intestine is herniated and is dying, well, that's a different story. That if you don't take care of it, you are not going to do very well. So all of a sudden, the risk of surgery, which is there, all of a sudden the benefit went, you know, because you need to get it done. It's a perfect example of a risk-benefit situation. As well as, you know, these various numbers. You know, I mean, we do a lot of research. We do a lot of, you know, what's best for certain kinds of patients undergoing a certain type of operation. We know we got to get the level of pulmonary hypertension to a certain level in order, because the outcomes are poor if your level of pulmonary hypertension is very, very high. So that's, again, a very risk versus benefit assessment based on what is the cause of your pulmonary hypertension, what is the, you know, what does the science tell us? I mean, it's what we continue to do, and why why I'm still in the game, because there's so much work left to be done and research left to do. But Dr. Elwing is absolutely right. I'm in the field in which people have pulmonary hypertension due to these organized clots within their pulmonary arteries. And we know the best way of relieving that pressure is to get those clots out of there, right? And once you do that, within minutes, all of a sudden your pressure goes, right? Yay. And so we've known this for a lot of years. So that's a different situation. A patient's pulmonary hypertension due to chronic clots is much different than a patient's pulmonary hypertension due to liver disease, or patient's pulmonary hypertension due to lung disease, or patient's pulmonary hypertension due to left heart disease. So it's a complex mix, but this is the reason why we have sessions like this. We want to communicate with you. We're part of your team. You're part of our team. Let's talk.
And I think there's just no absolute answer, just as Dr. Auger is saying. Like, there's not a cutoff that says green light, red light. There's most of the time we're at the yellow light, caution. So,
yeah, and it's like, in life, right? Absolutes are always, you kind of, you never say never in medicine, or never, you kind of, and yes, that's absolutely right. If your operation is 4 hours long versus 20 minutes long, yes. The longer the operation, the greater the risk, the greater the stress on your body if you're under general anesthesia. But that's put into the risk versus benefit equation. But never is a tough word.
I would like an absolute answer.
Are you paying attention?
So if you have a medical or a road ID, you're in an emergency situation, so we don't have that lead time. What would you advise to have on that bracelet for the ER? Should we have our my chart file? Should we, what would you think would be a good thing to put on something like that?
Well, I think certainly number one is pulmonary hypertension or chronic thromboembolic pulmonary hypertension. And in most cases, yes, if you're on a blood thinner, absolutely. But in most cases, when medical professionals see that, let's say you're in a rural community, those things will make them stop and take notice. Because it's something they don't deal with all the time. We do. And if you can't advocate for yourself, please have one of your family members advocate for you so that we can get you into the right setting as soon as possible. Now, if it's a true emergency and it can be life-threatening, well, obviously they have to do with what's in front of them. But they need to reach out to us because I will tell you, we will guide them through every step as much as we can. And then if you need to, as I said earlier, once you're stabilized, we can bring you to our center. But pulmonary hypertension, chronic thromboembolic pulmonary hypertension, anticoagulation, and I don't know what else you can fit on there, but certainly any crazy allergies that you have. Those are key words that I think would really get an ER attending to stand up and, take notice.
and you can set up your emergency alert on your phone too. So even if they can't get into your phone, they can get your emergency information, your contact information, your center information.
So, yeah, and this is where your care provider takes a greater role in, advocating for you when you can't yourself. I mean, so, yeah. It's the toughest situations are the emergency situations, but that's Please. Okay. Are you paying attention now? Okay.
Thank you,
Gee
sir.
whiz.
My general question is about, are there different ways that general anesthesia is administered? And is one way or another more or less risky? The question comes out of my specific experience dealing with the oncologic gynecologist, where I had a situation where they would normally do a hysterectomy and biopsy, and she scared the hell out of me about general anesthesia. They put a tube down my throat, and instead they sent my case to their tumor board and decided it wasn't a good risk to do. What is general anesthesia, and are there different ways that it's administered, and what should I be afraid of and not afraid of?
These guys are killing me up here.
Just because it's white, that doesn't mean... The answer is yes. There are different general anesthesia approach, and each bears its different risk between the gases administered, the kinds of medications. You know, there's, for example, there's a milky medication that people are administered to get them patients sleepy and to begin the process of general anesthesia that anesthesiologists, if they know they have pulmonary hypertension, they know pretty much to avoid. Okay, this is kind of written. This is folklore. I mean, this is part of the book of anesthesia. You don't do this in people with pulmonary hypertension, and so there are all sorts of anesthetics being used, which is the reason why we're not just saying it because just to say it. If you have the option with elective surgery, come to a center that works with patients with pulmonary hypertension, with a team of cardiac anesthesiologists who know what to avoid that milky medication, for example, that know they do it every single day, and they're very familiar with the proper protocols for general anesthesia, proper for pulmonary hypertensive patients, as well as, you know, we're forgetting about after the surgery, have a critical care team that can take, you know, an intensive care team that can take care of patients, and God forbid, if there is a problem, all the tools are available, the machines and all the things that we need to take proper care of you should there be a complication are available at that organization. And that's why we keep on, you know, the message has been pretty clear, I think, right?
Absolutely.
Okay, that if you're having problems, you know, and you have elective surgery, please work with your team and get you into an environment that's safest for you. Right?
Absolutely.
And I think that the conversation about what kind of anesthesia really is one that needs to take place way before your surgery date. So the planning of, do we do this by a gas to put you to sleep? Or do we avoid that? Or is this something we really can use a local and kind of, or a epidural? So we have options to work around things. We've done almost awake knee replacements in people we needed to do it. We just spinal anesthesia. So we have been very creative to keep people as well as possible with complex surgery. So, but it takes a conversation, and that is something that we just appreciate the fact that you tell us early enough so we can start that for you.
And I also want to say, I'm surprised Fran hasn't hit me by now.
Oh, boy. No,
You know, we're focusing a lot, listen guys, we're focusing a lot on, which we should, the surgeons, you know, the pulmonary hypertension docs, you know, the anesthesiologists, but I said, you know, don't forget about post-operative care and the intensivists, but God, what about the nurses? Okay, the nurses have to know about your pumps, okay? They have to, you know, you have to have the pH coordinators who know, oh, hey, did you bring in your meds? You know, we have to substitute. If you can't take anything by mouth, we typically have to have the other means of providing pulmonary hypertension care and medications. If you're on the ventilator and you can't take anything by mouth, and that capability needs to be at the hospital that you're having your surgery. And so the key thing that I always, you know, I stress out over is damn pump work again, and you know, and have, you know, how many times have I called you?
I was just
How many
thinking,
times have I called you?
Get a knock on my office door.
Fran!
Got a minute? No, but because we all have to work together, and we can't act on things we don't know about. So if there's something that you need in the line of surgery, what we're trying to say is it doesn't have to be an absolute no. I mean, sometimes if you're sick enough, we're going to say no right now, and we can get you tuned up and get you ready for it. But don't think that, oh my gosh, I'm going to have to live with this forever. Not in this day and age, not in modern times in PH. We have a lot of options. I think of an example of a patient of ours who had to have endoscopy and was on an oral prostacyclin. And we had to literally, because we hadn't had anybody in that situation first, so we called the guy who knows the most about it, Dr. White in Rochester, to say, what do you do? And he was kind enough to outline what he did and what he did with his anesthesia department. And we followed his suggestions for this particular patient, missed minimal doses, and did very well. So we are beyond us here. We're all over the country. We can pick up a phone, and if we have an issue, Dr. O'Shea, can you just take a look at these imaging for us? Our goal is to help you get what you need in the proper amount of time, in a safe situation, and get you home, and preserve that RV. So, don't think that, oh gosh, I'm not going to be able to do this. Have that conversation. So we could do all that planning. It's okay, we do it all the time. There's a lot of coordination taking care of pulmonary hypertension patients. And, we pride ourselves in the fact that we put all the pieces together. But it's what we do every day.
Yeah, guys, haven't you noticed when you're walking in the hallways here, hey, it's good to see you,
Yeah.
we kind of, it's a very tight community. Obviously, we're all in this together. So just, we're here for you. That's the reason why I flew all the way to California to come here today. This is what we're all about. This is the, okay, how much time we got?
We got a few minutes.
Keep firing.
But I gotta just say, from my perspective, isn't it wonderful to be able to ask about, can I get an elective surgery? 25 years ago, we weren't able to ask those questions, right? We have meds that keep people well. We have teams that are experienced in almost every big city in this country. So we are able to have these conversations. I think it's awesome. How many surgeries during your time at UCSD did you do on very, very ill pulmonary hypertension patients to try to rescue them from their blood clots?
Well, a lot.
Yeah, so we've amazing work that's been done. So anyway, that was just my 2 cents.
And things are getting more complicated in order to, make your lives better, but that's the whole point, isn't it? Okay.
Okay, question.
Sorry, we just have one from the live stream audience. Should we take our CPAP with us to surgery for recovery?
Absolutely. Great question. Great question. Yes, they should pack it up and bring it with them.
Yeah, it's better to do it. Every hospital's a little bit different in the United States, it seems. It's always better to bring your equipment. It needs to be checked by the staff and the engineering at that particular, at the hospital, and make sure it's okay to use. And if it isn't, they will provide a machine. So it's a little bit different in every hospital in the U.S. But yeah, it's a good idea to bring your stuff with you, your pump, your medications, your CPAP machines, if you can, if you have time. This young lady up here.
I just wanted to ask a question. Back in 1980, when he was diagnosed, they didn't have anything. They didn't know anything back then. So what would happen if we would have had surgery? If we would have had to have surgery back then?
Well, I'm the oldest. I will speak up now because I was there back then. And yeah, it was a different world back then, and it would have been a big problem. And that's the reality, my friend. I mean, history. And we're in such a better place now than we've ever been. Thank God. And I think that it wouldn't have been a happy day because we didn't have anything. Yeah, I was just having that conversation last night with somebody. Yeah.
So I do have a question. What about if you're on a research trial and you have a research medicine? How do you do that? Fran, what do you tell your patients?
Oh, that's very interesting. I've not actually been in that situation. Honest to God, in all my years, I've not been in that situation. What do you tell your patients?
So the people who are on research studies, we definitely try to keep them in our institution if at all possible, because we can work through our research pharmacy, get their meds, keep them on whatever med they need, or bridge them to another med, communicate with the sponsor if we have an interruption, so we don't get their study that they may really want to continue We
I
don't want to
see.
interrupt that in any way, because they might want to continue that after they have their surgery. So that's one special circumstance where people may not think about it, but that requires a little extra finesse.
Yeah, thank you. Yeah, that's important. That's a really good question to bring up. And I think the other thing too is, when you talked about the 1980s, right now, there are so many new drugs in the pipeline right now that are, still in phase 2 or phase 3, entering phase 3. If we come back here in, the next 4 years, this conversation might be totally different, because you may be on very different medications that are going to work in a different way, and hopefully, alter disease progression. So we've come a very long way. And certainly if you have to have surgery, there's no reason to think that it can't be worked out. And again, as we said, risk-benefit ratio is very important when we're assessing patients. But we want to make your lives and the quality of your lives better, and to live longer. But always just engage your PH team, please. And give us enough time to do what we need to do to get you at the optimum for whatever type of surgery you're going to have.
Well, I'll take issue with that a little bit. I
Okay.
think if we're here 2 years, 3 years, 5 years, 10 years from now, the same themes are still going to be true, even though the medications are going to be better and your life extended. But the same themes of, hey, talk to your team, talk to your, just work together. I mean, I've been doing this a long time, and I will say that pulmonary hypertension practitioners are some of the most committed to their patients I've ever seen, and oncologists are fantastic, and go right down a list of care provider teams. But over the years, I've been so impressed by PH groups and how committed they are in order to make your life the very best it can be.
We have about 7 minutes.
Yeah,
Okay.
no, keep coming.
Questions. I have a question after that too.
Oh, geez.
I have a question. I want to know, what do you tell people when they're on medicines that they're doing themselves, but they can't do them themselves anymore? Like Tyvaso, or inhaled treprostinil, or a sub-Q pump that the nurses may not run. But how do you deal with that?
So they're not able to handle it anymore.
Because they're really sick.
Yeah.
They've got something going on that, or they could have a pneumonia or something like that. They're really sick in the ICU.
So obviously, we want to keep them on the therapy or that particular drug class that they need to be on. So it becomes our responsibility, if they're sick in the ICU and they can't do this. Okay, so what do we replace in this situation to keep, again, that right side of the heart where it needs to be and not overstressed and working as best as it can be? Now, that may mean, depending on how they progress and how they recover, we may have to try an alternative method of delivery. But everybody's different. So we would have to, as a team, and certainly get the patient involved, and the patients, I can't thank the families enough, or their caregivers, to decide what way we're going to do this, because you may still need a prostacyclin. If they're in the hospital, obviously in our institution, when they come in with a subcutaneous medication, our policy is to switch them over to our pumps in the hospital and give it intravenously, and then when they go home, they go back on their subcutaneous medication. If they're not able to do it, we have to come up with a plan that's going to work for this patient and take into consideration their whole socioeconomic status to get them on the right medication that they can sustain. So it's very individually based, but it doesn't mean that we're going to say, well, no prostacyclin for you. No, we just have to figure out what's going to work for you in this new situation that you're in. Is that?
Mm-hmm, yes.
We have a question back there. Or,
No, it's just back to the bracelet. I'm sorry. I'm really sorry.
I'm sorry.
why don't you stand up?
So for the medical bracelet, I think the most important thing you can do is just put your PH provider's name and number on it, so that, of course,
Good
pulmonary
idea.
hypertension, but also having that contact, it lets them know who to call. And a lot of times you'll get one of the APPs that will get the call, or a nurse who's triaging it, but it kind of creates that contact for you.
Yeah.
Hi, I have a question about, like during surgery, generally general anesthesia is you're intubated during that. And with me, I always desaturate when I lay down, and so I need oxygen when I'm laying down. And when I had surgery, they said they spent an extra like 30 minutes trying to get me off the ventilator, and they couldn't do that right away. So I just have a question about, like, is there any advice as far as, like, transitioning after surgery as far as the ventilator? Because I do much better when I'm, more upright with my oxygen. So is that something that you could communicate to, like, the team as far as, like, coming off of the ventilator?
Well, I'll speak to that a little bit. I'm a critical care nurse by history. Spent a lot of years at the bedside in critical care, which I still miss, honest to God, every day. But anyway, that's a good question. I think if you're on the vent, the goal is, for everybody, is to get you off that vent, but how that path follows is very different for every patient. I would think that positioning is really important in assessing as you wake up, to help you help yourself get off the vent. And most critical care nurses know that. And then there's so many ways to monitor you to see if you're ready. Are you oxygenating well? Where are you in that process? So I think the staff should be able to understand that. But it's very, very different for each patient. The goal, obviously, is always to get that tube out. We don't want it to stay in there. We need, right? I mean, we don't want you to develop complications from extended intubation.
My training is actually in critical care medicine, and so, we don't operate in a vacuum. We do understand, especially, if you're intubated, it's going to be hard to communicate, but, your family members, can communicate with us. Hey, listen, she's, she always desaturates when she's low, blah, blah. We have a bucket of strategies that we can use in order to get people off the ventilator safely when it's appropriate. And absolutely, as Fran said, everybody's goal, is not, hey, how long can we keep this person on a ventilator? That is not our goal. Our goal is, how can we get this patient off the ventilator as quickly as possible? And perhaps you might need a transition period where you're on a non-invasive, meaning provide you with some support without actually putting the tube in your throat. So those technologies are currently available, and most patients, by the way, are very grateful for those. And so, yeah, there's lots of strategies. But that's what I meant about, it's not just about anesthesia, it's not just about surgery, but it's post-operative care too. That's critically important to understand how to administer it safely in people with pulmonary hypertension.
Early extubation, early mobility. There's a lot to be said for the incentive spirometer.
Can I add to that?
Yes.
Sure.
Yes, ma'am.
The third time I was put on the ventilator, I told the anesthesiologist and the nurse and anybody I saw in my room that I felt like they would, if I was on the ventilator, if they would roll me on my side, then maybe I would come off better, because I also desaturate when I lay down. And so they did. They kept me on my side while I was on the ventilator, and I came off from it a lot easier than I did the previous 2 times.
Yep.
So, but I made that clear to my doctors, try this. I don't know if it will work or not, but laying on my back is not going to help me.
Well, that's a great example of advocating for yourself.
And communicating.
There's a doggy here.
Oh, yeah, the dog's in here.
The dog has a question.
Alrighty, well, all so much for joining us today. And please remember to fill out your evaluation forms for this session. If you go to the PHA 2022 app and click on this session, in the agenda, an evaluation form should appear, or there's also a paper copy available at the Resource Center. And so the next breakout sessions start at 11. You can look in your program book or on the app to see what you'd like to go to next. And please don't forget to visit the research room to contribute to some to some research at the Cortland and Dunwoody rooms. But yeah, thank you so much to our panelists for sharing their expertise
Thank
today.
you.